Chaos exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Thank you, everyone. Welcome to Chaos Work in Progress rounds. I'd like to begin by acknowledging that chaos and most of us are based on the traditional, ancestral, unceded territory of the Musqueam, the Squamish, and the Tsleil-Waututh nations. I myself am based in my house in the Okanagan, which is the home of the Silix Nation. And again, all these territories are unceded territories which we have been on as occupiers. Today, we have a very interesting session, and we have two speakers. And the title of the session is How Behavioral Insights and Behavioral Science Can Be Applied to Health Systems and Public Health. And this will be presented by Dr. Alex Sutherland, who's the Chief Scientist and Director of Research and Evaluation at the Behavioural Insights Team, and Sasha, who's Director of the Behavioural Insights Team for Canada. Alex is Chief Scientist of Evaluation and Research. His recent published work has been on police body-worn cameras, and he's led a number of large-scale randomized controlled trials in education. Before joining BIT, Alex was at the RAND Europe for 5.5 years and spent 3 years coordinating and teaching research design quantitative methods at the University of Cambridge. Prior to Cambridge, he worked at the Center for Criminology at the University of Oxford and the DPhil in sociology, also from Oxford. That explains why he spells randomized with an S instead of a Z, I guess. Sasha Tregebov, I'm sure I murdered that and butchered it. Sorry about that if I did, is Director of BIT Canada, the Canadian branch of the group. Sasha and his team have been working with Toronto Public Health, the Public Health Agency of Canada, and others to address behavioral dimensions of COVID-19 pandemic. They also work with regulators, governments at all levels, and nonprofits to achieve environmental, social, and economic policy goals through rigorous applied behavioral science. Sasha has a master's in public policy and administration and previously led Deloitte's Behavioural Insights practice. Over to you, gentlemen, and we're looking forward to your presentation.
Thank you so much. A kind introduction and a kind invitation to speak to this group today. I know both Alex and I have been looking forward to it, and a special thank you to Sean for doing all the work coordinating and helping us get oriented to the interest and work of the group. I'm going to go ahead and share my screen here. Alex and I have prepared some slides to support our presentation. And there's a couple of goals for the session today. We want to, hopefully in a sort of fun and relevant way, introduce our field of expertise and practice, behavioral insights or applied behavioral science, share a few case studies of areas that we've worked in health systems and public health that we hope will sort of spark some ideas or insights or questions from this group as you relate it to your own research priorities and interests, or frankly, just your own personal life interests as well. Don't want to say too much about the organization. We were founded in 2010. We started out as part of the British government, which is why we have such a generic name, the Behavioural Insights Team, because at that time we were just the Behavioural Insights Team in the UK government. We're now independent of government, giving us this really unique opportunity to work with researchers, public sector organizations, nonprofits, et cetera, all over the globe. And we are indeed all over the globe, both in terms of where our teams are based and also even more broadly where we work, including some quite fascinating work in lower and middle income countries, as well as places like here in Canada. The dream come true for me to open up the Canadian branch of the Behavioural Insights Team in 2019. So we're pretty new in terms of our Canadian presence. And, we'll talk more about our work as we go through the next 15, 30 minutes of the presentation. But fundamentally, we work with partners across different sectors to design and test interventions or new approaches informed by behavioral science. And generally speaking, Alex can speak much more competently to this than I can. Generally speaking, we test those ideas through field experiments and generally some form or flavor of randomized control trial. And at this point in our experience, we do have loads of that experience sort of running these randomized evaluations. But I do just want to take a step back. This term behavioral insights, it's maybe a little bit jargony. It's not necessarily something that everybody is familiar with. So I just wanted to sort of briefly introduce this concept. And I want to do so by way of a game, or at least this is what my very nerdy colleagues and I would characterize as a game. You might not share that articulation of it. But what I'm going to do is I'm going to show you a list of words. And I'm going to give you about 30 seconds of extremely awkward silence. And I'm going to ask you to remember, without writing them down, as many of the words as you can. You're seeing why you may disagree with my characterization of this as a game, I imagine. So I don't have a timer going here, but again, I'll give about 30 seconds for folks to look at the list of words and try to remember as many as they can. I do this exercise quite often, and I've never gotten through the 30 seconds without blabbering on. So I'll sort of call it there. And then if you happen to have a pen and paper handy, or just a Word or Notepad window open, if you want to go ahead and write down as many of the words as you happen to remember. No worries at all if it's not convenient for you, if you've got your hands full. Not a critical part of the exercise. Game, I mean. Okay, and then we're going to try a little technology integration angle here. We've got this Slido poll. I'm not sure if you've seen this used before, but I'm going to ask you to go ahead to on your phone or your computer to slido.com, slido.com, or I suppose you can scan this QR code. I've never done that myself. But I presume it works. And enter the code here, 135909. And then we just got this little, multiple choice, select all that apply. Which of the following words do you remember? So hopefully this is working. It seems to work about 95% of the time. But if you can go ahead and jot down which ones you remember there. Try to be patient. I'll give another 10, 15 seconds for anybody else who wants to participate in this highly scientific poll that we're doing here. Okay, I think they've stopped rolling in. So thanks for the 10 of you who bore with me for this little exercise. So, we've got a relatively even distribution here, yawn being the most commonly remembered word at around 80%, then snore at 70%, nap and sleep at 60%. There's only one sort of issue here, and it's that the word sleep wasn't actually on the list. The other three were, but for those 60% of you, the 6 out of 10 of you who remembered the word sleep, this is an example of false recall. And let me reassure you, there is absolutely nothing wrong with you whatsoever. It's perfectly normal in sort of larger sample studies that are similar to this. It's usually between 44 and 55% of people that will falsely remember the word sleep. And this very simple, I think sort of, somewhat trivial exercise, I think reveals something actually quite fundamental, and for me anyway, something quite interesting about how our brains work, how our cognitive processes function. And in particular, it points to this fact that subconsciously or non-consciously, our brains are constantly doing this work, right, that we're not aware of. Frankly, the word sleep should have been on that list. I showed you, and if I can go back here to it, I showed you 15 words that all fundamentally relate and are connected to each other by the concept of sleep. And so your brain is just filling in those gaps. And your brain is doing things like this all of the time, filtering out extraneous information, adding in missing information. And one of the sort of fundamental ideas of behavioral insights is, what if we were to bring a more nuanced and realistic model of how people behave, including all of this hidden work, this non-conscious work that our brains are doing? What if we applied that to the design of our processes, of our policies, of our choice environments? Now, this notion has been articulated much more sort of clearly and rigorously than what I just said as the dual process theory of cognition. And the dual process theory has sort of, competing flavors and articulations, but the one that we at the Behavioral Insights team tend to prefer is that of Daniel Kahneman, a Nobel Prize winner in economics, although actually a psychologist by training, who likes to use this metaphor to explain the dual process theory of cognition, of having two systems of thought. So he says there are really sort of two ways in which our brains operate in the world, and therefore by which we operate in the world. System one, which is this sort of fast automatic brain. It's the brain that adds in the word sleep, even though it's not on the list. Again, it's fast, it's automatic, it's reflexive, and it relies on a range of cognitive heuristics or shortcuts as well as biases. Now, of course, we have another system of thinking as well, which he refers to as system two. That's our slow, deliberative, analytical brain. I think just at an intellectual level, it's sort of interesting. This metaphor and the research behind us is sort of interesting and revealing. But the implications of the division of labor between these two systems are what's really important. And in particular, I want to sort of call your attention to how powerful the influence of system one is. So system two, that slow, deliberative, analytical brain, is truly effortful. It's incredibly energy intensive. And we really can't use that system too often. And so system one has evolved basically as the sort of dominant way that we navigate through our world. We're making thousands, tens of thousands of small decisions and judgments every day, and we can't possibly do a full cost benefit for those. It would be impractical and it would be far too taxing. And so we really rely on our system one. And this is generally fine. It's an efficient and effective division of labor. In fact, it's desirable. It's more than fine. But there are some situations in which we really, really want people to, or we need people to activate that system two mode of thinking. But we often don't realize how powerful the influence of system one is. And so the I guess takeaway that I want to share with you is, when we are designing processes, communications, and interventions on the assumption that people will use their system two, we have to be extremely careful. And we should challenge ourselves to think about how we might design for people's system one instead, to work with that automatic mode of cognition, rather than requiring people to operate in that more effortful system two. And so that brings us to our sort of working definition of behavioral insights. Two of our colleagues, Alex and I, other leaders at the organization, Michael Halsworth and Elspeth Kirkman, recently wrote a book simply titled Behavioral Insights for MIT Press. And I think their definition is very good. It's the one that I prefer, where they refer to behavioral insights as an approach that uses evidence of both the conscious and non-conscious drivers of human behaviors to address practical issues. So differentiating it from behavioral science writ large in terms of its focus on concrete and practical issues. And so you could sort of read this as saying that uses evidence of both system 1 and system 2 modes of cognition in human behavior. Now, if you're sort of, many of our audiences obviously are not sort of behavioral science practitioners themselves. And so we've developed a framework for professionals with different training and different backgrounds to be able to apply at least some of the sort of fundamental precepts of the behavioral science literature. And we call this framework EAST, and we'll refer to it a little bit later in the presentation. And I think it's just worth sharing in its own right. And so basically we say, look, if you want to boil down a lot of the most important and sort of well-supported findings in behavioral science, you can translate it into 4 ideas. So if you want to encourage a behavior, whether it's at home with your kids, with your loved ones, or whether it's in your professional environment, think about how to make that behavior easy, how to make it attractive, how to make it social, and how to make it timely. So it's a surprisingly powerful, it's sort of in some ways a little bit simplistic, but it's a powerful framework and one that I hope that you might find useful in your own work and in your own lives. And we'll explore that a little bit more. So we've applied this type of thinking and this sort of framework in the broader literature that sits under it across quite a few domains within sort of health system and public health. So, certainly recently with COVID-19 in particular, communicating public health guidelines, how do we motivate people to observe mask wearing guidance from public health professionals, from doctors, increasing healthy behaviors, whether it's related to physical activity, sexual well-being, et cetera, encouraging the uptake of health services. How do we get people to attend to primary care and to engage with the health system in ways that we know are going to promote long-term, more positive long-term health outcomes. The first example that I want to give you, though, is around aligning prescribing behaviors among professionals, among clinicians, and in this case, family doctors in particular, to sort of clinical guidelines or best practices. And in particular, this work that we did in 2014, 2015, focused on decreasing the sort of overprescription of antibiotics. And now, most of you probably know this much better than I do. I'm far from a physician myself. But antimicrobial resistance is a critical concern in Canada, as it is worldwide, and family medicine is a focus of antibiotic stewardship efforts for several reasons. It accounts for a large proportion of overall antibiotic prescribing. Prescribing practices have been linked in the clinical literature to antimicrobial resistance, and there's also quite extensive variation between family doctors in terms of the rates of prescribing, which suggests that there's scope for improvement. And so the intervention that we developed here in collaboration with Public Health England and antimicrobial stewardship experts was really informed by some core, fundamental principles from behavioral science. So in particular, it used this concept of descriptive social norms in informing family doctors who did have much higher rates of prescribing, that were in the top 20th percentile on an adjusted basis in terms of the rates of prescribing, that the great majority of practices in their area prescribe fewer antibiotics per head than yours. And the idea here, this goes back to that social part, of the East framework, make it social, is that often one of the shortcuts that we use is, instead of weighing up the costs and benefits of behaving in a certain way, we simply look to the behavior of our peers for cues on how to behave. It's a very powerful heuristic. When the behavior of our peers is invisible to us, we are missing that cue. So the idea was to share this data with people in the hope that it would influence them. We also know that who sends a message really matters. That's another shortcut we use. We assess the credibility and relevance of the messenger rather than simply assessing the relevance and credibility and rigor of the message itself. So here we were lucky to have the Chief Medical Officer of Health, who, of course, because it's the UK, sorry, Alex, has a very fancy title, Professor Dame Sally Davies, who qualitative research indicated would be a highly credible messenger for this population. And then we also gave 3 very practical, clear, and actionable steps for reducing prescribing behavior. The results of this intervention, this letter, we tested this through a randomized control trial, were quite dramatic. So here you can see a graph showing the differences. So in September, before sending the letter, this was in 2014, you can see the rates in our control and treatment groups were identical. And then you see a meaningful and certainly a statistically significant gap with the sending of those letters when we see our October measures and onward. And then because of this sort of success we were seeing in the data, this letter was rolled out to the control group in April, and you can see at that time the rates become the same. So overall, this very simple, extremely low cost communications intervention reduced the rate at which antibiotic items are dispensed by 3.3% over the 6-month period, which, well, as we'll see on this next slide, here equated to 73,000 doses. And of course, not all antibiotic prescribing happens in family medicine, in primary care, but if this were rolled out nationally, which it actually now has been, it would reduce overall antibiotic prescribing in England by almost a percent, which happened to be the national goal for reduction in antibiotic prescribing as an AMR measure. What's interesting here, just before I pass this over to Alex, is that this really sparked, this work was published in the Lancet, and I think resonated quite a bit with the stewardship community. And there have actually been replications. I know of some in Italy, in the US, in Australia, and even one quite recently in Ontario. And they've actually had quite a consistent effect sizes. And there was even a follow-up study in the UK using a different evaluation methodology, using a difference in difference design that demonstrates that this has continued to be effective. It wasn't a sort of one-off shock to the system in terms of prescribing behaviors. It continues to be effective in England, where it was first implemented. So hopefully a sort of neat example that resonates with you in terms of how to very practically apply this understanding of the shortcuts we take in our cognition to critical issues in health systems. And I think with that, I'm going to stop sharing here so that Alex can share his screen for another example.
Thanks, Sasha. Let me just find the right screen to share. Can you just let me know if you can see that, Sasha? Is that okay?
Yes, although you do have a separate window up there, I think, with the timers, which is superimposed. There you go.
There we go. Okay. Great. So tough act to follow. Following Sasha, I will try my best. I'm going to talk to you about kind of reducing hospital appointment no-shows. This is kind of one of our, again, classic pieces of applications of BI. And it's trying to answer the question, how would you reduce the amount of hospital appointment no-shows? And I should say we've published a paper on this, and there's a reference at the end, which I can share in the slides. So what we did in this, again, a classic piece of kind of application of behavioural insights and nudges, I suppose is the phrase that you might be expecting to hear at some point, is testing a range of text messages. And we ran this as a randomized control trial using different insights from behavioural science. And these text messages kind of already draw on the principle of giving people a timely reminder. If you're going back to the EAST framework, we talk about things being timely. In the control situation, we tested a standard message confirming the appointment, which you can see on the screen. Just take a second to read the appointment, this text, and just think about any issues you might have with the text itself. Just put yourself in the position of receiving this text and thinking about what you've got to do next if you need to cancel or rearrange. So at the very least, one pretty basic issue is that you might not have the letter they sent you to hand, and certainly you probably wouldn't bother trying to dig it out and find the number. So in the first treatment group, really, we just simply added in the phone number to make cancelling and rearranging the appointment easy. Again, going back to our EAST framework. In the second treatment group, we built on this and added in a social norm, which is basically, well, as also the point about we're expecting you, we've added in this true statement that 9 out of 10 people actually attend their appointments, and we keep the number in. And in the final one, we added in the cost to the NHS of a missed appointment. So it's approximately £160, as was, and kept the number in as well. And we think that this kind of relies on the idea of reciprocity. And for those of you who don't know, the NHS is seen as something of a national treasure in the UK. And so we think that people would feel bad about kind of wasting resources when in effect it gives them free healthcare. So just for a moment, think about which version you think had the greatest impact. I'll remind you, so you had the control, just adding the telephone number, telephone plus social norm, and then telephone plus cost to the NHS. So just have a think, and I'll talk through the results in a moment. So in the control group, you had about 11% of appointments as no-shows or missed appointments. For those of you who thought adding the telephone number would have a big impact, it did change it, but not massively. It did reduce missed appointments, though, as you might expect. Adding in the social norm, however, didn't actually change anything, which was a surprise. It's quite interesting to think through why that might be the case. And then finally, when we added in the cost, that actually did have quite a big impact, and certainly a significant impact on the numbers of the proportion of missed appointments. So it's actually quite a meaningful difference we tested the result in terms of the results here. And I mean, in terms of like thinking about the actual reductions, it's like a 25% reduction between control and this treatment arm. So if you're thinking about like scaling this up, there's different ways of thinking about scaling and the likely impact. We estimated it would lead to nearly about 6,000 fewer missed appointments in the same location. This is one hospital, Mile End Hospital in East London. But if we actually scale this to England, it would lead to something like 400,000 fewer missed appointments. And if you're really fast at arithmetic, you might have worked out that 400,000 times 160 pounds is something like 64 million pounds. Now, even if it is 1/10 of that in reality, the intervention itself is almost costless. So the cost benefit of this intervention would be enormous. And for those of you who are interested, there's a link to the paper there. Now, we kind of haven't planned to speak to any more examples. And these are only a couple of examples of the work we've done. I mean, just to give you an illustration of the sorts of things that I'm currently thinking about, and then I'd love to hear from the group on the call what you're working on if you have any questions. Like, I've been thinking about ways of preventing drug dealers from entering the market. I've been thinking about public health approaches to violence prevention. More generally, the team is working on topics on obesity, smoking cessation, and vaccine hesitancy as well, as Sasha mentioned. I should also say that a lot of what we talk about, and maybe we'll come on to this point, is that a lot of this just sounds like common sense. when you say it out loud. But what's astonishing is just how rarely these sorts of simple fixes and solves are actually implemented. And that's partly, what we spend our time doing as well. And I should also say that this is supposed to be a kind of work in progress, and we've only really presented you two things that have finished quite a long time ago. But if we think about BIT's work being to make policy making, decision making kind of more rigorous, more evidence based, and informed by behavioural science, then we really are just getting started, even after 10 years kind of in the game. But I think I'm happy to stop there and open it up to you and find out what you're working on, and just have an interesting discussion about whether you think there's applications to what we've talked about to your own work or the problems you're working on, and of course to answer questions more generally. So I'll stop sharing there, and then we can come in for discussion. Thanks.